Okay, so hi everybody, welcome to the Plains to Peaks Regional Network call, learning opportunity for March 18th, 2019. Today we're gonna talk about all of our various efforts related to opioid overdose prevention, and then towards the end of the call I'll also go through some results from the regional network coordinating organization that our members of our region filled out. So just to get started, let's do a round of introductions, and usually what we ask is for me to read off of the list of participants, and then for you to introduce who you are, where you're from, and what your role is in your organization. So Carol Runyon, you're actually at the top of my list. Do you want to start?
Sure. I'm Carol Runyon. I'm the co-director of the Program for Injury Prevention, Education, and Research at the Colorado School of Public Health.
Thanks for joining. Next on the list I have the name is listed as T. Crew, so if you could unmute yourself and introduce yourself.
Yes, this is Tom Crew. I'm with the Department of Health and Human Services in Nebraska.
Great, thanks Tom for joining. Next, Gary Maurer.
Yeah, this is Gary Maurer with the Utah Department of Health, and I am the Opioid Crisis Response Coordinator.
Thanks, Gary, for joining. Next, I have Tracy Hardy.
Hi, this is Tracy Hardy. I'm the Project Officer for Core SFIP and for PFS awardees at CDC.
Great, thanks, Tracy. Next, I have Allison Rosenthal.
Hi, this is Allison Rosenthal, and I work for the Colorado Department of Public Health and Environment, and I'm a prescription drug project evaluator.
Great, thanks, Allison. Next, I have Joe, oh gosh, is it Filiomeni? Or John, sorry, not Joe. It looks like you might be muted, John, just to give you a heads up. Oh, there you go.
Yes, Filiomeni, that's right.
Okay, cool.
Yep, I'm John Filiomeni. I am a program coordinator for Nebraska Department of Health and Human Services.
Great, thanks for joining, John. Let's see. Next, I also have Jeannie Beats, and Jeannie said that she's listening via computer, not on the phone, but she is also from Nebraska. So I'll introduce her. And next, Katie Olson.
Hi, this is Katie Olson from the Colorado Department of Public Health and Environment. I am also a prescription drug project evaluator.
Thanks, Katie. And Kate Cohen.
Hi, yeah, this is Kate Cohen. I work with the Colorado Department of Public Health, and I work on communications and policy.
Great. Next, Mandy Slag.
Hi, everybody. Mandy Slag, North Dakota Department of Health Injury Prevention Program Director.
Thanks, Mandy. And Tara, is it Hogan or Hogan? I'm sorry, I don't know how to pronounce your last name.
It's Haugen.
Haugen.
I work for the North Dakota Department of Health, and I deal mostly with the National Violent Death Reporting System and the opioid side of things.
Great, thanks for joining today. Next, I have Anna Fondario.
Hi, it's Anna Fondario from the Utah Department of Health and the Program Manager for Violence and Injury Prevention.
Thanks, Anna. And Cody Pinks is next.
Hi, I'm Cody Pinks. I'm with the North Dakota Department of Health, and I'm an epidemiologist.
Thanks, Cody. And then Nareesh.
Hey, this is Nareesh and the Utah Department of Health Informatics.
Great, thanks, Nareesh. And Sally Thigpen.
Yeah, hi everybody. This is Sally Thigpen. I'm at the Injury Center at CDC, and I'm an evaluator.
Thanks, Sally. Allie Maffey. I think you just joined, so we're doing introductions. Oh, sorry, what did you say, Allie?
I just joined and my audio took a minute.
Okay, sorry, I caught you. I saw your name pop up and.
Yeah. Hi everyone, Allie Maffey, CDPHE.
Thanks, Allie. And then Peg. I can't hear you, Peg. Okay, well, Peg is also from Nebraska, so I'll introduce her as well. Did I miss anybody? There's a couple phone numbers on here as well. I don't have names assigned to them, so if I didn't call your name, please definitely introduce yourself now.
Colleen, I just dialed in, so this is Peg.
Hi, Peg. Thanks for joining. Anyone else?
Sarah Brandspiegel's here. I joined a little late.
Sorry, Sarah. Thanks for introducing yourself. Okay. Well, thank you all for joining today, and it's good to see some new names, likely because you are people that work on opioid overdose prevention in your various states. And that's the topic that we chose to discuss today. And just a little bit of background on how we're going to participate. We had talked about in our Plains to Peaks advisory team that we met in person last September. It was nice to do a little bit of like round robin to share what we're doing in our various states and then have a discussion about the work. So, so thank you again to those of you who joined or more intimately involved. And so to kick off, we thought it would be helpful just to hear a little bit of background, kind of brief couple minutes on what you're working on for opioid overdose prevention. And I just listed the states alphabetically and can go through. And I know not all states are on here, but I know that we've got a couple people from Colorado. So Allison or Katie, do you mind sharing, you know, kind of high level what the strategies look like in Colorado?
Sure. Who would like, Allison, do you want to go first? Do you want me to go first?
Sure, you can go first.
Okay. So a lot of the projects that I am working on in terms of opioid overdose prevention in Colorado consists of helping make it easier for providers to access and use the prescription drug monitoring program. Anything from training to also surveying to see what can make it more user-friendly and integrating it into various workflow options. I am also working on a lot of our state's naloxone standing order work as well. That's kind of the really high level.
Hi, this is Anna from Utah. Sorry, I was just going to ask a quick clarifying question with your PDMP. Is your PDMP housed at the Department of Health or elsewhere?
It is currently housed at our Department of Regulatory Agencies, which has the Board of Pharmacy.
Okay, great. Thank you. Thank you. Sorry.
No problem.
But we do have like a full data set that we get from DORA to analyze for population health, and our role is actually like written into statute. So that's an interesting kind of dilemma that we face. And then this is Allison, and I just want to also share kind of briefly some of our educational programs that we do. We have like a lot of our strategies around increasing provider education around safe opioid prescribing. So we fund local grantees to set up events in their communities about this topic. And we also did a pilot to bring academic detailing to Colorado in a couple of counties that were in urban and rural areas. The other thing we were working on was exploring unspecified drug poisonings to try and gain more information to improve our drug overdose surveillance.
Great, thanks. Anything else to add or any questions specific for Colorado? And we have discussion questions on the next slide, but just any clarifying questions?
Colleen, it's Anna. I have some questions that I think would be helpful, but we can ask them when we go through the discussion questions, just to kind of get an idea of if people's PDMPs are housed within health departments or their regulatory agencies. It'd be nice to kind of know that. And then other questions, so other states can start thinking about this as well, is just questions about academic detailing and perhaps like who's being targeted for academic detailing. It would be interesting to see what states are doing around that. But we can go through that after we go through kind of the broad overview.
Okay, thanks. Yeah, I made note of that. Thanks for having those questions prepared. That's great. So I know that there are a few people from Nebraska on the phone, and I'm skipping over the other states because I didn't hear anybody introduce themselves from Iowa, Kansas, Missouri, or Montana. But let me know if anybody done since we did intros. I don't think I see any names. But for Nebraska, I don't know who's the best person to provide just like a quick overview of the strategies that you're working on for opioid overdose prevention. I don't know if it's you, John, or someone else.
Honestly, Felicia's probably the best person to be asking, although I don't think she's on the call today. I can make a couple of statements here, much like Colorado was saying, working on the, obviously the PDMP portion of it. We've got some academic detailing that's starting to ramp up. I think we're actually just starting to get the detailers educated. We're also working on the toxicology, postmortem toxicology screening, trying to get clean information, detailed information, good information out of that. Obviously, naloxone, we've got available standing order from the state, so literally anyone can walk into, a CVS or whatever pharmacy they want, and they can get it without a prescription. So there's been a big push to try and get anyone who has individuals in their orbit to try and get them looking out for these at-risk individuals. We've been working with the behavioral health regions to get naloxone available for them. I guess this is more on the behavioral health side, but these behavioral health regions have naloxone kits available, and they are more or less handing them out to the the sheriff's departments and whatnot. So these kits are available in sheriff's vehicles, in law enforcement vehicles. So a little bit on the diversion side, but with any luck, we can use it to get a little bit of prevention going as well.
Great, thank you. Any specific questions for John or anybody else from Nebraska to add?
Well, Colleen, this is Peg, and I could just say John did a great job. And he's right, Felicia would be the one that would be able to.
Yeah, I don't think she could make it. Yeah.
But I can tell you that that a lot of work here has gone into getting the PDMP really so that it's just a whole lot more accessible. There's been some enhancements done to it, that sort of thing, and it's actually through a contract. The department has a contract with an organization houses it, and then as John said, they've done a lot of work on the naloxone access. There's I've heard some of the PSAs that have been going around, some of the media that's been done, and and then they also did a pain management document. That's been a while ago already. That's probably a year ago, to help educate providers. So.
Great. Thank you. Going to the next analyst in North Dakota, I know that Mandy invited Tara and Cody, who work more closely on opioid overdose prevention work. Do either of you want to provide a overview?
This is Cody Pinks. I am, like I said, the EPI with North Dakota Department of Health. I am overseeing the National Violent Death Reporting System. And as a state, we are applying for the Overdose Data to Action Grant for the opioid funding. We are already collecting ED data through our Essence system. We already are funded, like I said, for NBDRS, and we proactively started collecting overdose information as well with that system. And I got more surveillance, but I do know I can attest really to the prevention efforts. That's not really where my understanding and work is, but I do know that we work directly with our PDMP, which is under the Board of Pharmacy here. And some of the work that we've been doing is connecting PDMP to EVE through NASFIS. And so what we're trying to gain is hopefully finding out deaths so that can get marked in PDMP, so no one's picking up any prescriptions for someone that's passed. I don't think we have a whole lot of that happening, but it's one of our efforts to prevent abuse. And then we're also looking at potentially connecting our PDMP through our health information network, so that people that are overdosing and being seen in the EDs, there could be potentially a link there to let the PDMP know that the risk factor for that person. And I'm speaking on something I don't know a whole lot about. I just know that we're looking at connecting more to our PDMP so that they get a better picture of risk behaviors of individuals in North Dakota.
Interesting. That's cool. Thanks for sharing that.
Yeah.
Tara, is there anything else you'd want to add?
Not really. I mean, just from the violent death reporting side, we actually are seeing more meth overdoses than we are the opioids in North Dakota.
Interesting, yeah. Okay. And then last, just on the list of attendee states, Utah. I'm not sure, Anna, who you think is best to provide the update. Gary, or I'm not sure.
Hi. Yeah, I'll start, and then if Gary and Naresh want to jump in at any time, feel free. So we have several different opioid-related grants within Utah. And so I'll talk about several different activities, but they come from a variety of different funding sources as well. But like many of the other states, we've done a lot of work with our PDMP, and our PDMP is housed within our regulatory agency as well. But we do have access to pull that data down into our health department survey so that we can utilize the data and look at it as a public health data source. And we've done a lot of different projects with the PDMP. We've developed a patient dashboard within the PDMP that has, risk indicators that providers would automatically see, and we're currently developing a prescriber dashboard within the PDMP that should be finalized late spring, where prescribers will be able to look at their utilization metrics as well as other prescribing behavior metrics. We are working on academic detailing efforts and starting to ramp that up. We are focusing on dentists and oral surgeons along our, we call it our Wasatch Front. And then in another high burden area, we are focusing on all controlled substance prescribers. We are also working, we do have grants, community level grants. 6 of them are with our local health departments. 2 of them are with local substance abuse authorities doing prevention work. They're focusing primarily on uptake of the clinical guidelines and local community efforts, particularly with changing or trying to influence prescribing behavior. We also have an opioid fatality review committee that's been meeting for a little over a year now. And I can talk a little bit. Well, so what we've done with that is we've identified, areas of review. So the first one focused on looking at deaths with gabapentin and opioids. The second review looked at high burden areas. The third review has looked at overdoses when individuals have been released from an entity. So whether it's a substance abuse treatment facility or a hospital because of post-operative care, or a jail or prison or an institution. So looking at deaths that have occurred after a recent release. And we have some recommendations that have come out from that. Other dashboards that we're building, like many other states, there's a public-facing dashboard where you could visualize opioid data, but we're also developing what we're calling an internal opioid dashboard, so that local health departments will have more real-time access, and that would have more timely information and more and smaller numbers that we wouldn't be able to release to the public. So we're working on that. And then we've also implemented a media campaign, and that focuses on signs of an overdose, risks of taking opioids, and naloxone. We have an open application system for naloxone. We also have a standing order for naloxone. And we are working with 211, so with United Way 211 to implement a substance use disorder hotline. And then also working with our Department of Public Safety to implement a drug monitoring initiative, or I guess to upscale our drug monitoring initiative. So those are just kind of very high overarching activities that we have been working on. So Gary and Naresh, I don't know if you have anything you want to add to that.
Yeah, I'm good. That's pretty much it.
A lot.
Yeah.
Okay. Are there any questions for Utah or any of the states before we move on to our discussion questions? Okay. Well, thanks for the high-level overviews, everybody. I know that this work is really complex, so it's hard to do it in a couple minutes, but it's just helpful to see where we're all at with the work initially. So here's some initial questions that we had brainstormed for the discussion, but I thought, Anna, since you had brought up a couple questions, and I think everybody said where their PDMPs are based or housed, but did you have something more specific that you were hoping to go on?
So just following up with Nebraska, did you mention, is your PDMP housed within your regulatory agency?
It's actually through a contract. The health department has a contract with an agency which is NEHI, which stands for something. Nebraska Health Information something, I don't remember. So it's not in a regulatory agency. I guess we hold the contract, and then the work actually is through them.
Okay, but not within the health department.
No, I mean, but I can explain very well, because we have a staff person that he's doing all the work to help get people signed up for the PDMP and all that kind of stuff. So it's kind of a joint effort, I guess.
Oh, okay. And then
it was an agency that had been doing some of that kind of work for a number of years before we were funded. So then we've just been able to work with them to really expand it. And I know they've spent some of the money for different enhancements, like providers wanted, and I'm not going to remember because I haven't been in any of the meetings for a while, but they wanted different enhancements to be able to, I know one thing it'll do, I believe it creates an alert, if you go into the system, if the provider goes to the system and there's red flags, somehow they've got it set up so that there's sort of an alert about various things. So. Okay.
Well, one of the other questions I had for those working with PDMP data, and if you have a dashboard of opioid data, and if that data is included in your public or your dashboard, I guess, does everyone have a opioid dashboard for their state? And if so, do you have your PDMP data included in that dashboard?
I can speak a little bit on Nebraska. We don't yet have our dashboard up. We've got the Comprehensive Opioid Abuse Program grant that we're working on, and one of our requirements is to have an externally facing data dashboard. We should actually be having that the first version released right about May 1, but it's going to be very limited in its scope initially. We hope to eventually incorporate some of the PDMP data in there, though. Obviously, it's going to be properly aliased, anonymized there. It's going to be scrubbed of everything that cannot be identifiable, cannot be outwardly facing, but we do hope to have it included in there, yes.
Okay.
Hi, this is North Dakota. We do have a dashboard that's mocked up for drug overdoses. So it's definitely not public facing yet. It's still kind of in a test site, but we have our PDMP data on there. And in addition to PDMP data, we also have, we're going to include EMS and crime data and what, just to kind of overlay the data across the state. And we do have it down to county level as well. Small numbers obviously won't be shown, so I'll aggregate, but we hope to keep adding on more layers so you kind of get a better picture and view of what's going on across North Dakota.
For Colorado, Katie or Allison or Maria, I saw your name on there too. Do you want to talk about our dashboards?
Sure. Hi, this is Maria. I am an epidemiologist for our Colorado opioid overdose prevention team. I was having some technical difficulties, so I missed the intro. But we do have PDMP data in our dashboard. It's actually the Colorado Consortium for Prescription Drug Abuse Prevention dashboard. So we provide data, PDMP data. We also upload some ED hospitalizations and hospitalization data, and then our Office of Behavioral Health uploads some treatment admissions data. And then we're in the process of creating, that dashboard is more focused on opioids, so both heroin and prescription, but we are starting to build one out at the health department that's going to be focused more on all drug overdoses, not just opioids.
Oh, and I just wanted to add, this is Allison, that Scott Preshabell from North Carolina compiled a whole spreadsheet of opioid dashboards, and we can share that resource with the group if people want ideas for enhancements, or if you're just getting started. We used that list when we were designing the prescription dashboard update.
That's helpful to know. Thanks.
Yeah.
Yeah, actually, that would be wonderful.
I think some of the things that we've found challenging here in Utah, we've started developing these dashboards as well, is just working with our community partners to understand what they would need in these dashboards and if they would be useful. Did anyone else find that challenge, or did you just kind of build it based off of what you felt at the health department was needed or needed to be visualized? Or how did you engage your community partners or local health departments in the development of this? If you did at all.
Yeah, Allison or Katie or Ray, did the consortium engage community, like their community partners for that one? No.
So the process was iterative, and we didn't invite a ton of feedback from local partners. Maria, correct me if I'm wrong, but I remember we like compiled like what data indicators we got most often for data requests, and then chose those ones to be visualized in the dashboard. And then we presented the design to the Colorado Consortium's data and research work group, and then kind of further refined from there. However, the data and research work group, it's, I guess just depending on the month, it can be more of a like public health, like academic audience. So we didn't necessarily go to community partners that weren't as data literate.
I think it's a interesting or a good question though, and I'm just thinking about, I know we had created a lot of community profiles for our community partners, and Maria, are you hoping to transition that more into like a dashboard?
Yeah, and I think that's really actually helpful to think about, because I feel like, well, just in Utah, I feel like we've kind of gotten stuck trying to get a lot of feedback. So then there's this scope creep of what the dashboard is. And so it's nice to see how other health departments have addressed developing their dashboards and how involved maybe other, community partners are in that development. So thank you.
Yeah, I think it's a good reminder that we should be engaging, our community partners or local partners in as part of the development. I know our data visualization manager, who's not on the call right now, but is kind of responsible for a lot of creation and oversight of multiple dashboards for our violence and injury prevention work. He's started including like a feedback link in each of the dashboards, so that even if they maybe weren't as engaged in the creation, we can get their feedback along the way and make changes as needed.
Yeah.
I will say I don't think we've gotten a lot of direct feedback yet. So, but I know that, that through our states grant through CDC, and then also for the opioid data to action grant that we're also applying for right now, working with local partners on opioid overdose prevention is pretty critical. And so making sure that we're providing the right data to them so they can make data informed decisions and action.
Right. We're actually in the middle of getting our, obviously we're in the middle of getting our the first iteration of the dashboard out there. So as was mentioned here, do you just release something and then tell them about all the features you've put in, despite them calling them bugs, or do you get all your feedback and visions first and create something based off of that? So we're actually going to put out a first, kind of skeleton, bare bones version, have probably about 20 to 30 people from around the state, and law enforcement, professional associations, researchers. Who else do we have here? The behavioral, public health departments, and then solicit feedback at this kickoff meeting for this dashboard.
Yeah, that's great. Thank you. So maybe another thing too is, so in Utah, just going with some of the discussion questions that Colleen has, the first one, what successes have you had related to your opioid overdose prevention work? So I feel like we've had a lot of success here in Utah, and we have started to see significant decreases in our heroin and prescription opioid overdose rates, but we can't really say it's one specific intervention or effort that we've done. It's kind of a collaboration of a lot of different things. So I'm curious to see kind of what your thoughts are in your states, if the combination of all the different efforts are making an impact in your state, or if you're still kind of seeing increases.
I think in Colorado, we're still trying to figure that out. I mean, I think there's so much that's happening in the state, not just directed by us at the state health department, but by the consortium to prevent overdoses, and with researchers, and and with the Office of Behavioral Health on the more treatment side, that it's hard to say like our work, any decrease is attributable to the work that we've done. So I think that's like a challenge. We're trying to figure out how to sort through that, I think.
Yeah, I mean, we've had a lot of calls from different agencies wanting to know what we've been doing to bring our rates down, but we can't really say, that it's one specific thing. I think it's a collaborative effort. But I mean, we're glad we're seeing these decreases. I can't remember if there are other states. I'm trying to remember the other states that have seen decreases. So it sounds like Colorado, not sure. What about Nebraska, North Dakota over the past couple of years? Have you seen increases or decreases in your rates?
We've been seeing steady increases in our overdose rates, unfortunately. Across the board for, I think, just about everything, actually.
We're a pretty low incidence state, and likely we're going to catch up before we reduce.
Yeah. Someone mentioned meth. We've been seeing huge increases in our meth rates. And I want to say the last time I looked at the data that our meth-related deaths have surpassed our heroin-related deaths.
Yeah, I think that was North Dakota that had mentioned that as well. Or I mentioned the meth rate.
Nebraska as well. We've seen meth is now number two overdose-related drug of choice there. And we've got that kind of classic urban and rural divide there, where you've got more meth in the rural areas and more opioids in the urban areas.
Yeah, I was going to say something similar. I think, and Allison, you can probably speak more to this, but as we're assessing, next steps for our local partners around opioid overdose prevention, we have been hearing from some rural partners that that meth is more of a substance of concern than opioids. Is that true? Am I capturing that correctly, Allison?
Yeah, and I think that some grantees are even trying to look at like substance use in general, and just to be more inclusive of some of the other substances that they're seeing rising. And I think other grantees are also trying to link some other like mental health concerns that they've been noting, and just kind of like looking at these diseases together as like diseases of despair.
Right. And I think that just kind of goes along to the other questions that Colleen has on here about challenges that we have faced. So I think that's one of the challenges we're starting to face, is that because we are now starting to see the decrease in opioid-related deaths in our state, and seeing these increases in meth, how do we address just substance abuse or substance use in general and drug overdoses in general, but still making sure that we're addressing or at least still advancing our efforts with opioids and continuing that decrease. And so it just has brought up a lot of questions with a lot of our partners and our coalition, and then just even with the new NOFO that has come out, and how, where we're headed with our opioid overdose prevention work and what our next steps are. So how do we look at this a little bit more comprehensively, and maybe even getting down to more of the shared risk and protective factors of those issues.
Yeah, and I feel like you're reading my mind, because earlier I had made a note to myself to ask the group. I think especially, thinking as we think about moving upstream, or I know that that an important area of interest, especially for the CDC, is adverse childhood experiences, and so what's shared across these all of these substances that we can be working on from a prevention lens. So yeah, I was thinking similarly. I'm curious. So it sounds like Utah is kind of thinking about that, and Colorado has that come up in conversations in Nebraska or North Dakota?
In Nebraska, we've been looking into these things. I mean, we obviously know that an ounce of prevention is worth a pound of cure, but it's been an uphill battle with stigma in many cases. These toxicology screenings are they're getting to be used more frequently, which is giving us better information, which is in turn allowing us to properly identify the problem. Some of our more rural counties are hesitant to look too deeply into causes of death, which might point toward drug-related causes, which obviously hamper our ability to better target prevention efforts. I know, kind of backing out just a little bit, this last week over in DOJ was hosting this COPE seminar. A lot of it was more enforcement and diversion based, but in many cases they were talking about the adverse events. They were talking about how to better create a how better to remove the stigma. West Virginia apparently has a wonderful model for this that I need to look into a little bit closer and try to make, I hesitate to say necessarily recovery efforts, but healing efforts, more of a community action and less of an individual trying to get up from a personal failing.
Mm-hmm. Did you say that they have like a media campaign around it, or just programmatic efforts around that?
West Virginia?
Yeah.
You know what? I will include. I gotta find exactly where I lost the information. I know I was given a couple of websites actually by what's his name, a regional coordinator for strategic prevention framework for prescription drugs. So I will get out some information either during this in the chat window there, or afterward I will contact Colleen with some information to disseminate.
Yeah, I'm happy to share out any information. I'm interested in seeing that as well.
Certainly, I'd be happy to pass it along here.
And I know that you had also asked about academic detailing. I don't know if you want to talk about that a little bit more in depth.
Yeah. Well, we just kind of focused our academic detailing efforts based off of looking at different data, and we're focusing on dentists and oral surgeons. And I know there hasn't been a lot of effort targeting that specific group. I was just curious if other states were looking at that. And I know we don't have a lot of time, Colleen. I feel like we could probably do 5 hours talking about opioid efforts, and I could learn so much from all these other states to help us with what we're doing here. But I was just curious about what the target of academic detailing is, and I even had questions about evaluation. But those are things that we can also discuss offline too.
Yeah, and I know in Colorado, Allison, I don't know if you want to give a quick, kind of overview of how we approach our academic detailing efforts. But it was a challenging to implement, I'll say.
Yeah, it was really challenging. We partnered with the Colorado School of Pharmacy, and they helped us find detailers, and they oversaw some of the contract or sort of managing the detailers themselves. And we decided as a group of planners to focus on a broad variety of specialties, including dentists, surgeons, primary care providers, and family medicine practitioners. And we identified 6 counties in Colorado that had some of the higher burdens of too risky prescribing opioid practices. And then we just ran into problems like maintaining fidelity to the intervention. So we'd had a training for all the detailers, and one of the detailers in particular didn't really understand that academic detailing is different than like group education lessons. And so some of them scheduled some of these group sessions, and then it was just hard to like separate some of the data from those. And one of the other challenges was just recruiting. We had given detailers like a list of providers in their areas that we thought met the criteria of the people we wanted to target, and those lists sometimes didn't end up being accurate, and it took a while to clean that up. And then just having like a low response rate just by doing those cold calls was like discouraging for detailers. So yeah, and I just based on kind of like all those difficulties, Colorado's like not sure if we want to continue with the project. We're still like kind of like figuring out like what provider education stuff we want to do for the overdose data to action grant application. But yeah, it was definitely a learning experience.
Yeah.
This is Mandy in North Dakota, and I do know that our oral health program is working closely with dentists, but unfortunately, our epidemiologist for the oral health program is on maternity leave, so that's why she's not at this meeting. So I can get the details of that if you guys want, but I don't have a lot of information about it.
Yeah, that's just interesting to me that and we have an oral health program here too, and it's not something that's come up in terms of prescription drug overdose. So that's just interesting.
This is Tara. Oops.
Go ahead.
This is Tara from North Dakota. I helped Grace with what Mandy was talking about, and we did up like a Qualtrics survey to send out to the oral health providers about their, just their training, their knowledge on the opioids, if they're using the PDMP, just to kind of see where our providers are sitting, and then we can work from that, their responses.
That's good to know. So I know that we're getting short on time, and I did want to quickly go over some of the results from our RNCO survey, but I did want to comment that first of all, really appreciate everybody's participation and engagement in the conversation today. And I think, as Anna said, we could likely talk about this or any topic area for a very long time to get really in depth on what our different states are doing. But I'm really hoping that that this is like a jumping off point maybe for some connections that we can make to continue this conversation forward. And if we want to have if there's any way that I can facilitate those connections or to think about if we want to continue this conversation in the future, or kind of seeing what comes out of our applications for the data to action grant, that would make sense to me. I do know in that grant there is like a peer-to-peer component, and so perhaps there will be some sort of structure to do that within that grant the CDC is organizing. So we'll have to see what comes out of that, those grant applications. But before moving on, are there any final thoughts or questions for the group? Okay, well, again, thank you for the discussion. I know a couple people said that they'd follow up with some resources. If you want to just email them directly to me, I can send them out to the larger group. And a big thank you to Anna for helping to facilitate the conversation today too. So if you, and just to let you know, Tracy Hardy from CDC said that if we have any need for information from states outside of our regions here, especially relating to dashboards, CDC can help make those connections as well. So you won't hesitate to reach out, Tracy. Thank you. So if you attended today just to talk about the opioid work, feel free to hop off the phone if you're not interested in learning about the results, but I'm happy to have you as part of them as well. So I'm going to pretty quickly walk through these because I know we're really tight on time. But on an annual basis, CDC and the Safe States Alliance sends out a regional network coordinating organization survey on an annual basis. It's kind of like a satisfaction survey and touch point to see where we're at with our participation for our region. So the data that I'm going to show you today is really specific to the Plains to Peaks Regional Network. So this first slide is just showing the organization types from our regional network, or at least from the respondents. And you can see that the majority of respondents work at a state health department. And then we had a few people from academic institutions, hospitals or healthcare organizations, or social service agencies. This next slide is, there was a question around the primary focus of professional work, and you could select up to 3. So you'll see that folks indicated that they work in program implementation, coordination, in terms of like the majority of participation, and then, or for the majority of the primary focus, and then that was followed by surveillance and data analysis, which is tied with coalition building, and then there's a few others. And again, you could select more than one on here, so I'm sure a lot of us wear multiple hats who took this survey, so it's just kind of good to see the various side of the professional work that we do. And then I thought I would share some responses around the open-ended questions. So there was a question around how the respondents' work has been enhanced or influenced by participation in the Plains to Peaks Regional Network. And there was a lot of comments. I tried to synthesize and narrow them down, but there were a lot of comments around the opportunity to create new connections with other states and networking, to learn from and share resources, and then also getting a better understanding of how we all implement our various grant activities, and just really opportunities to hear about others' experiences to inform the work that we do in our own states and troubleshoot any issues or questions that arise in the work. So that was really great to see, since this is a lot about peer learning and peer networking. And then some similar responses in terms of what the most rewarding aspects of participating in the Plains to Peaks Regional Network were. So again, opportunities to learn from colleagues, connect with other states, develop some relationships with people outside of your agency or your state, and really just connecting with others around injury and violence prevention work, especially those who have worked on similar issues and similar political climates. And I know that that's definitely come up in terms of some of our discussion on what's being addressed in our various legislative sessions and the bills that we're educating on as injury and violence prevention practitioners. And I think I have one more slide just around suggested improvements and ideas for better support. And so some of the things that came up were ideas around informational emails on anything that comes up or up and coming, or sharing of resources of materials, maybe in a more formal way that's outside of the every other month calls. And so I think typically people send stuff to me and then I'll send it up to the group, or I'll post it on our collaboration website, but happy to think through how we might want to do a little bit more resource sharing, especially around stuff that we're doing, in each of our states. Another thing that came up was around more information on shared risk and protective factors. And I think just more opportunities to come together and what we're doing. And I think especially this came up a couple times with just having the possibility of having an in-person regional meeting. And unfortunately right now we're limited in our funds to pay for our network members to come together on an annual basis within our region, and have been using the Safe States Alliance conference as our in-person meeting for our states. And I know that this is definitely something that I've heard come up a couple of times. And right now I know CDC doesn't necessarily have funds to support this, but there may be opportunities for scholarships from Safe States to attend the conference, just to make sure that we have more representation. And something to definitely keep in mind if there's like opportunities to leverage times when we may be coming together already, or we may be attending something in each other's states. So definitely something that I'm aware of. And I think I really loved the in-person meeting last fall because I thought it was a really nice opportunity to connect face to face. And I wish that we could do it more, but our geographic spread of our regions makes it, our states and our regions makes it a little bit more challenging compared to the regional networks like in the Northeast where they can just drive quickly to see each other. So, just to let you know, the Plains to Peaks Advisory Team took a look at these survey results, and I can send out the full report to the group that was sent to me by Safe States, but we're really just wanting to make sure that we keep in mind, what's working well and where there's suggested improvements, and as we're planning for our every other month learning opportunities going forward. Are there any questions or comments based on the survey results? So with that, then our next learning opportunity is Wednesday, May 22nd. And please let me know if you have anything that you really want us to cover. I do have a couple placeholders and ideas for upcoming calls. And actually, Mandy, I may be following up with you because I think you had offered to maybe facilitate the May one. So I'll follow up with you in an email. And then just to share with this group, I'm actually, we're expecting, my husband and I are expecting a baby in mid-May, so I likely won't be on the May call, but we will definitely have it covered from Colorado's end, and I'll be back. Actually, you'll probably see me at the Safe States Alliance conference in September, so we'll have it covered, but I just wanted to share that. You might not be hearing from me, but someone else from our team here in Colorado.
Well, congratulations. That's really exciting.
Yeah, thanks.
Congrats. Thank you, Colleen.
Yeah, thank you so much for the discussion, everybody, today. It was really great to hear a little bit more about what people are doing to help you with birth prevention. All right, we will end the meeting. Always feel free to reach out if you have any thoughts or feedback. I'll probably also be sending out a little survey just to get a pulse on how things went today.
Thank you.
Yeah, we'll talk soon. Thank you.
Bye.